It's the Metro on WDET. I'm Robyn, Vincent. We begin by looking back 5 years ago. That's when drug overdoses were killing more than 3,000 people a year in Michigan. It was the worst the state had seen. Behind that number were parents, sons, and daughters, people who'd been trying to get well for years. That number is coming down. By the state's early count, last year had the fewest overdose deaths in more than a decade. But the people who do this work are cautious about it. Fewer deaths may not mean fewer people in danger. Addiction touches lives in different ways. For many of us, it might be indirectly. One analysis put the cost to Michigan last year at $38 billion. Lost work, lost wages, courts, treatment. Now there's money to fight this. Millions from the settlement with the maker of OxyContin, Purdue Pharma. Detroit gets a share, and it's deciding how to spend it now. Our guest is at the center of some of those decisions. He leads Detroit's health department and founded Dearborn's before that. Ali Abazeed, welcome back to the Metro.
Thank you so much for having me. Really excited to be back here.
So I want to talk a little bit about this settlement. According to Attorney General Dana Nessel, Michigan will receive $154 million from Purdue Pharma. The company shut down on May 1st. I'm wondering how that money is being distributed to localities like Detroit to fight addiction, what you understand about that.
Yeah, no, it's a great question. And so the last time I was here, I was in my role in Dearborn, and I got to share a little bit about the work that we were doing there around harm reduction, around really increasing access to tools, life-saving tools. I've been in the role now in Detroit for about 2 months and really understanding the lay of the land and where and how we do different sort of opioid use work, substance use work. And a lot of that's driven by some of these settlement funds that are going to help us continue to do the good work that we do in Detroit. Not all of it happens at the health department, but as you know, when Mayor Sheffield appointed me, she mentioned that the city of Detroit is now a health and all policy city, which means basically everything that we do as a city government, all of our operations will be looked at through a health lens. And that includes stuff like public safety, and that includes stuff like transportation and planning and zoning and economic development. And of course, that includes the work that we're doing around opioid use disorder. And so working with my colleagues in the housing department, working with my colleagues in the mayor's office, we're really focused on using these funds to continue to do some of the work that we're doing around quick response, which means connecting folks post-overdose to resources and wraparound services, connecting with folks who are unhoused or don't have stable housing, who are living through substance use disorder or opioid use disorder, to connect them to some of those resources. And then in my department, we have a pretty robust harm reduction campaign going that we're planning on increasing access to life-saving resources like naloxone and test strips. The idea here, though, is that, though we've seen these declines across the country and across the state, you always see that asterisk that says disparities exist for racial groups. In Michigan, we're talking about Detroit there. We're specifically talking about Black Detroiters. And so that's the work that we're looking at going forward as well.
Right, because the deaths don't fall evenly.
Mm-hmm.
As of 2023, Black Michiganders were dying from overdose at nearly, 3 times the rate of a white resident. And that gap has barely closed. I mean, you run a public health department in a city where the majority of residents are Black. When the state celebrates a falling number, does that number mean the same thing in Detroit?
We should celebrate when numbers go down for anyone, because generally that means that there are good trends that we can follow for all groups. And at the same time, the way that I practice public health, the way that I've always thought about, the work of improving health equity, using all these buzzwords, is that it only matters insofar as we're helping people closest to the pain. And so for me, my focus has always been people closest to the pain. And in Detroit, that is Black Detroiters, around a broad array of issues, whether it's, maternal and child health, whether it's, asthma, and then on this topic, whether it's, declining overdose rates. And so for me, when you talk about racial disparities, it's usually connected to decisions that have been made over decades, if not longer, that have been designed by us, by man. And so the beautiful part or the optimistic part about what human hands designed is that human hands can redesign that. And so for me, when I think about, well, how do you target racial disparities on this so-called intractable problem of overdoses or opioid use, it's not intractable. It's policy, it's resources, it's investment, it's oftentimes neglect. And so the my mandate, my charge overall from the mayor, from everyone that I'm working with in city government, is both how do we embed health lenses across city government, but for me, as just the chief public health officer who has a say in how these resources are going to be allocated, I want to take a look at how we're allocating these resources across housing. And what we know about housing is that it's intimately connected to your health. And so when it comes to opioid use disorder or substance use disorder, we see a huge link between racial disparities and housing availability or stability. That's an area where we can potentially target these funds, but also target those intractable racial disparities.
You're talking about public health as this very integrative strategy. And it has been integrative for a long time, but I'm wondering if this moment for you working under Mayor Mary Sheffield, if this moment feels different for you as a health leader, because you're talking about a widespread acknowledgement, somewhat of a reckoning here of how all of these factors play into one another. Is this moment different?
It's so different. And, I would counter that public health hasn't been integrative. I'm pretty critical of my field and have been critical of my field, especially during and post-pandemic. Public health is a field that began, our origin story began with a really radical idea at the time, which is that different people, based on who they are, the color of their skin, how much resources they have, they're at different risk of disease. That was a really radical idea some 150, 200 years ago when our field was founded. And so, recognizing that our field was born basically in defiance of a cultural norm, I would argue that over the last 4 decades, public health has grown into far too much of a technocratic field, one that is far too academic, far too comfortable in the ivory tower. Public health belongs on the ground, belongs in community with people. And so for me, I've always taken that approach. I was in the federal government during the pandemic, and I always want to be careful when I say this, not on the front lines like our healthcare workers were, but on the front lines of our sort of federal policy national response. And I saw firsthand the failure of public health, if I'm being honest. And look, it's hard to communicate about a once in a century novel virus where the guidance is changing daily, but I did feel that our field failed in doing the essential, which is how do we keep people alive? And I don't think we did a good job of communicating that during the pandemic.
I'm wondering what lessons from those failures you're taking right now into the work in Detroit.
Occam's razor, the simplest explanation, sometimes the right one. The biggest lesson is that people are people are people. I've worked in refugee camps in the Middle East. I've worked in the corridors of power in Washington, D.C. I've founded a health department, and now I'm in one of the most historic cities on planet Earth, working on some of the deepest and most serious health challenges that we see anywhere in America, here in Detroit. People are people. And so for me, recognizing that people are going to do things, people are going to make mistakes, people are going to do silly and dumb and not so smart things all the time. It's the old W.E.B. Du Bois thing about people are wondrous, they do wonderful things and they also do frightful things.
We love when anyone quotes Du Bois on this show.
There's a documentary coming out tomorrow that I can't wait for. PBS, got to plug that. And so I teach Du Bois in my classrooms because I think history is one of the best ways to look forward. And so for me, recognizing, especially in Detroit, focusing that we need to talk about these racial disparities without flinching. The 5 times higher maternal mortality rate amongst Black women than white women. That's something that I'm going to be talking about directly, whether it's Black HIV/AIDS rates, whether it's asthma rates, whether it's opioid use rates. We talk about those things without flinching. And for me, the biggest lesson is that we need to make sure that we're protecting people institutionally, because it's not about individuals doing things on a one-off.
It's the Metro on WDET. I'm Robyn Vincent. My guest is Ali Abazeed. He's the Chief Public Health Officer for the city of Detroit. We're discussing what the city is doing to work with other departments to improve the health of its residents and how this moment might be different. I want to start with the big picture here. You ran Dearborn's health department. Now you run Detroit's. What does success look like? I mean, we've just went over some of these big problems, which I want to point out you do not frame as intractable problems. And that's very hopeful. I think that's messaging that we all want to grab onto. But what does success look like in Detroit versus what it looked like in Dearborn?
You know, the scale is obviously different. We're talking about a city that's 6 times bigger, Detroit, than Dearborn. And my department, it's a 300-person department in Detroit versus 10 at most with temporary folks and then fellows. Nothing bothers me more in public health sort of circles than conversations that are circuitous, conversations that lead us to nowhere. Yet another sort of work group or task force, yet another convening of academics or practitioners, and this is not slinging arrows at any particular field, or convening of government workers like myself. I think for me, the fundamental charge is, do you believe that these problems are set in stone? Do you believe that they were ordained by any particular sort of divine figure? I don't. I don't think that anyone decided that Black Detroiters should have 4 times the asthma rate, or 3 times the asthma hospitalizations as their white counterparts. I don't believe that overdose rates need to be higher amongst any particular group or amongst refugee or immigrants or in a particular zip code. And so recognizing that, I think for me, success looks like, first of all, exercising a muscle, which is that we can do hard things. And, that's something that I'm really set on doing in Detroit.
What you're saying here, these circuitous conversations, what you mean is folks perhaps in an echo chamber lamenting these problems and not looking towards solutions. What does it look like to be on the ground, meeting Detroiters where they are, outside of the ivory tower, focusing on those solutions? What does that look like?
I started, it was an unofficial sort of slogan for the Detroit Health Department that's now become official. And I wish I came up with it, but I didn't. But I just started, quoting the line from the Jadakiss song about be outside. And that's really where public health belongs, is outside. We don't belong in an office, behind a desk, behind a computer screen. We belong in community with folks who are experiencing overdoses, with folks who are experiencing housing instability, with folks who are experiencing isolation and despair and loss. I mean, it's a difficult time out there. It's hard for people to survive. It's hard for people to have joy. And so for me, meeting Detroiters means, first of all, talking openly and honestly about all of this. And, those are lessons that I get out of just history. Again, recognizing that there are people in American society who've borne the brunt of myth and metaphor, of America sort of telling itself stories about itself that may not be true. And so for me, recognizing that Detroit is the epicenter in many ways across the country of so many things that have gone right and so many things that have gone wrong. And so recognizing that we have an opportunity here under a mayor who wants the biggest, boldest, most ambitious ideas, recognizing that public health is at a moment where we either decide to, ruffle some feathers or go against the grain, or we just continue along this technocratic path where we just silently capitulate or acquiesce to the status quo. I don't accept that. Again, it irritates me, borderline infuriates me that people in public health can be so passive in the face of sort of inherited concepts. Like these things are set in stone and we can't do anything about them. No, we absolutely can. I took my my job in Dearborn. I was in Washington during the during 5 years, but there was a particular flood in 2021 that happened across Southeast Michigan. I was still in Washington, but there was a comment that someone made. I wrote a piece. Me and my buddy did an investigative journalism thing or citizen journalism thing, and we published a story. And someone reached out to me about the piece and said, Ali, like the thing that you published was great, but you're making it seem as if like people that don't have money, that their houses weren't going to be flooded, as if to say that this is how life happens. People with resources are going to have better outcomes, and people without resources are going to have worse outcomes. That idea offends me, like really offends me, because then what that's implying is that these things are set in stone, they're permanent, where if you have less money, therefore you deserve poorer health or poorer outcomes. And if you have better money or more money, then you deserve better outcomes. Well, let's talk about the design of that. Let's talk about the architecture of poverty. And again, the optimistic thing about all of this is you can probably trace most of this back to policy, and policy is written and driven by humans. And so, yet again, I think what human hands designed, we can redesign.
Something that you keep mentioning here is poverty. And we know this has a direct link to people's health, of course. And there's a new anti-poverty department in Detroit. Over 34% of folks who live here are living here below the poverty line. What does the work look like for you leading public health in the city, working with the anti-poverty department? What is that going to look like?
Yeah, one of the mayor's big sort of announcements was bringing in Dr. Luke Schaefer, who's one of the foremost poverty experts on the planet, and also the co-founder of RX Kids, which that announcement was paired with the announcement that Detroit now has RX Kids.
Giving money to expecting moms and new moms without any strings attached.
No strings, universal, unconditional. So if you're a mother out there who's pregnant in Detroit and 40 or 34 or 35 other communities in Michigan, you're eligible for the funds. If you've had a kid in Detroit after January 1st, you're eligible for those funds. We've already prescribed over $3 million in Detroit to some 200 families. And so, that's one of the biggest anti-poverty measures possible. During the pandemic, when we had the federal sort of expansion of the earned income tax credit, we saw childhood poverty in this country plummet in half. And so we know that this stuff works. It's sad that it's a radical idea here in America, but in most other countries around the planet, they've already figured this out. Give families resources, make it unconditional, make it universal. And so we're working very closely with that office on a number of initiatives.
But the tension here, of course, is that all of this takes a lot of money and resources that Detroit doesn't have. I mean, what does it look like to take a more active approach when we know that there is a real big shortfall here in terms of having the money? I mean, you have millions to work with, not billions.
The thing about money is, when I was in Dearborn, I had $0 in general fund for 4 years. All of the money that we use to do things such as bring down the overdose rates 60% in Dearborn, such as working on bringing RX Kids. We didn't have a procurement office that did that. That was me and my small but mighty team going out there to get the funds to roll out RX Kids in Dearborn. The thing about money is that go get the ideas. And so one of the things that I've told my team in Dearborn and now in Detroit is the most important question is, what do Detroiters need? Forget about the political realities. Forget about the financial constraints. What do Detroiters need? We have the money in this country. We have the money in the state. And the idea is that we oftentimes in public health and in government, if we're being honest, we operate with too many sort of self-imposed constraints. We're told that here's a budget, now go operate from there. My guidance, my directives are quite the opposite to my teams. Go out there and find the best ideas, whether they're across the street, across the country, or across the planet. And then let's design it for Detroit, and then let's see where we can get the funds to roll it out. when you start with imagination, you're more likely to sort of have a better outcome than starting with a limitation around funding or political realities, et cetera. And so I'm not too concerned about money. I think my concern is that we don't have big enough ideas or bold enough ideas. I think that when you generate excitement, usually that leads to attention. I think that attention then leads to more funding, and I think that people should be investing in Detroit, and our city government is showing proof of that.
It's the Metro on WDET. I'm Robyn Vincent. My guest is Ali Abazeed. He's the Chief Public Health Officer for the city of Detroit. We're discussing what the city is doing to work with other departments to improve the health of its residents. When we come back, the part of public health you don't usually hear health leaders talking about, though this health leader has talked about a few of them already. But we're going to get into more of that. Whether a city has parks, whether the buses run, whether teenagers have anywhere to go. Stay with us. It's the Metro on WDET. I'm Robyn Vincent. I've been speaking with Ali Abazeed. He's the Chief Public Health Officer for the city of Detroit. We've been discussing what the city is doing to improve the health of its residents and how this moment feels different for the city of Detroit. Now we want to talk about the part of public health that we don't always hear health leaders talking about. And this ties into why this moment is feeling unique. Now, 2 years ago, now City Council President James Tate began the Protect Your Crown campaign, which is seeking to understand the state of mental health for 5,000 Detroit residents. I know that you're not part of his office, but I'm wondering if you can speak at all to what the city has learned from that campaign at this point.
You know, mental health, behavioral health is a top concern and priority for the mayor. And one of the things that I know is that, and here's the part, Robyn, when we talk about sort of just leading with imagination, oftentimes you can sort of be cast as, that guy that's, talking in the clouds, or
You're so idealistic, Director Abazeed.
I've heard
Gosh.
all of it.
Yeah.
And none of it bothers me, honestly. It's my God, like, are we just going to continue to do the same thing over and over again and expect different results? Or dare we try something new? Dare we try some kind of different ecosystem? Why is it that our imagination is usually reserved for, doing some of the most heinous and grotesque things as a society, whether it's our foreign decisions or otherwise. But when it comes to protecting people, when it comes to reinventing new ways of looking out for people, that's where you're cast away as being too idealistic. And so what I know is that mental and behavioral health, we've made some progress. At least we can talk about it now without people sort of casting you aside right away. And at the same time, I'm of the opinion that we're not doing nearly enough. I mean, it's wonderful that we can say things like it's been destigmatized, and I'm not sure that that's entirely true, by the way, but it's wonderful that we can say that compared to maybe a decade ago. And at the same time, the way that we're talking to people about what mental health looks like on a day-to-day basis, it's not a runny nose. It's not a migraine or a headache, although those things can show up as symptoms, by the way. But it's also not invisible, and I hope we've done away with that nomenclature too. It shows up in sort of missed, classroom time. It shows up in missed work time. It shows up in sort of a dent in our economy. And so what I know is that the way that we're talking and treating mental health, though we've made some progress, we're still nowhere near where we need to be, which is, how do we start providing some wraparound services and clarifying what those wraparound services are to Detroiters? Because we know, and the theme of today's conversation is that those disparities amongst racial groups persist, whether it's in terms of access, whether it's in terms of outcomes, whether it's in terms of how those outcomes then translate to more what we know as physical health outcomes. So we have a lot of ideas. We're taking a look at the lay of the land. There are some great people and great organizations in Detroit that do this work. And my goal is to sort of tap into all of that and help build an ecosystem where it's more integrated around mental and behavioral health as well.
Well, yeah, this is a two-pronged problem here, and you have astutely noted both of them. One is the stigma, and the other is the access.
Hmm.
So slowly but surely, there are ways to chip away at the stigma. Certainly with the messaging that's coming out of the city of Detroit, that can be one way. I drive by a billboard every day that advertises for folks to think about their mental health on Brush Street in the North End. But what does it look like to improve access? Can you give me like a solid example of what that might look like? Because that's the other part of this battle.
That's the moonshot. And look, in Detroit, we have a lot of stakeholders and a lot of actors, and city government doesn't have control over most of them. And so, in public health, we're particularly interested in our school-based population, because where else do you have a reliable population from 8 a.m. to 4 p.m. on a day-to-day basis? That's a wonderful population, but we don't have any control over the schools, at least our public schools. And so for me, it's taking a look at some of our school-based clinics, whether that's with, organizations like Henry Ford Health, or some of our healthcare providers, or some of the wonderful groups like DWIN who do some of the work within those environments. For me, the moonshot really is, how do you create an ecosystem where across every neighborhood in Detroit, not just downtown, you are familiar with what your government provides for you. And then it's our job as government to provide a no wrong door policy. And so that if you're walking into a neighborhood wellness center, which we have 7 of them at the health department across every single neighborhood, you are then connected to a community health worker who's looking at you, assessing you, who's not just doing your cholesterol and blood pressure, we do that now, but also is helping refer you. Are you a pregnant mother? There's RX Kids in downtown. Are you someone who, is struggling with your mental health? We're working on this sort of mobile health clinic, and we want to connect you to social workers. I have a lot of ideas that I'm working on, and 2 months in, it's hard for me to sort of restrain myself from sharing them. But the idea here is, we have a wonderful health department, some 300 folks that work for us across sort of 20 different programs and divisions. One is taking a look at what do we do, how do we do it better, and then 2 is, it's time to innovate. It's time to sort of upgrade the software. How do we take the Detroit Health Department to the streets, to the neighborhoods, and then how do we connect the dots so that we're all integrated in this health and all policies paradigm?
Director Abazeed, if I'm hearing you right, what you're saying is that moment when a Detroiter walks in to one of your clinics, that is a crucial moment, that is a valuable moment, can be a pivotal moment if your clinicians are taking the time with the people that they're meeting, and they are viewing them holistically, and they are asking them about their mental health, and they are asking them about how many guns they might have in the home. They're asking them about things that maybe they're not talking about with anyone else. This is the moment.
It is. And, it's our clinicians, it's our community health workers. Shout out to every community health worker out there. Those are the folks that are doing the frontline work of public health. And so for me, it's recognizing that this department, this organization, does a lot of things really, really well. and does some things that need to be upgraded quite a bit. So, one of the things that I'm taking a very close look at is exactly that point at which we have contact with a resident, that first contact. It is the single most important point because you have one chance at that first contact. And if that person is connected to their government and they're led to a hour-long phone call, they're led to another department that's not answering, or they're led to a website URL that's deactivated or disconnected, that's a shame on us. And so for me, it's one is taking a look at this really hard work ahead of us. How do we best connect that person to the no wrong door policy? Detroiters deserve the absolute best. Detroiters have also been subject to some of the worst things that have happened. And I think that those things have been a byproduct of decisions that have been made by man. And so as we continue to sort of take a look at what we do, what we offer, how we connect with folks, the simple, and it is a simple idea, very difficult to implement, but a very simple idea. Let's make sure we have the best first contact with our residents so that we're connecting them to all the breadth of resources that we offer as city government.
But how do you get them that first contact? How do you get them to walk through the
Oh,
doors?
Detroiters are not shy. They let us know. And that's twofold. One is they're not shy. They do reach out to us quite often, and we have the numbers to show that. But the second part, and this I think touches on a really important point that you're bringing up, is it's our job to take City Hall to the neighborhoods, not the residents' sort of job to come to us. And so that's something that I've led with in all my government jobs. That's something that I believe very strongly here in Detroit. And again, it's a charge to my entire department to be outside, to take our work into the neighborhoods, to take them into the community and rec centers, into the senior centers, and to make sure that we're doing it. That's not ethereal. That's not too pie in the sky. That's get up off your desk. Let's make sure that we're designing programs that are touching our residents, and then let's go outside and make sure that we're making contact with those residents.
When you think about making contact with people and how important that is, and you're painting a picture of a different kind of public health, one that's hitting the streets, one where everyone in the public health department is not staring at a computer screen. They're out there in the world. It also has me wondering more broadly about interacting with people, the importance of socializing, of fighting loneliness more broadly, and how that is intertwined in public health, and where you see your role in trying to address that.
Social isolation is, one of the deepest problems in public health that I still don't believe is getting the attention it deserves. I think it had its moment, in sort of the zeitgeist. I think it had its moments in sort of the press, but it's been so obscured by just compounding after compounding, crisis and disaster in public health. And so for me, it's recognizing that, social isolation is a critical issue. I mean, we've seen some of the statistics, and some of it has been sort of, combed through with a finer sort of approach. But some of it's akin to, smoking a pack of cigarettes a day. We've all heard that. Whether that's accurate or not is another question. But that paints a picture, right? It shows you that there are real devastating consequences to social isolation. What we also know is that it's not just something that's amongst our most vulnerable, our senior citizens, and it is. But it's also something that we're seeing amongst young men, male loneliness, and the crisis of sort of male friendship. And so for me, it's recognizing that, these issues are all connected to a broad array of other issues. And not to sort of harp on it, but I will harp on it, but how we talk about housing in this country and the availability of housing, and whether or not you're suburbanizing or urbanizing or stability or unstable, all of that translates to whether or not you have access to, I think, our most fundamental resource, which is people, other people.
I mean, the fact that you're harping on housing is, of course, raising my antennas, because what you're saying to me right now, Director Abazeed, is that housing is going to be a priority for you in the health department, overseeing something that a lot of people would think is a very different category. And you're saying that these two things are intertwined. So in the last minute we have here, how do you see yourself helping to improve this, what you would not call an intractable problem of housing in Detroit and how it's connected to health?
We take our charge from the mayor, and the mayor has prioritized housing and having new units in the next 4 years, new housing units, affordable housing, and otherwise. There is no more important issue in public health than stable, safe, reliable housing. In the last month, we rolled out a sort of new intervention where public health inspectors are now accompanying sort of environmental inspectors and our buildings inspectors and working with our legal department on properties that have been deemed public health hazards. That's a new initiative where public health is already involved now, and those referrals, if they are violations, will be referred to the law department. And so that's a priority for the mayor, and housing is connected intimately to improving health. As we continue on, the way that we'll be involved, the way that I'll be involved is again on making it so that all departments are thinking with a health lens. That includes our housing and buildings departments, because we know that if you have safe, stable housing, your health outcomes are likely to improve as well.
Ali Abazeed, Chief Public Health Officer for the City of Detroit. Thank you so much, Director Abazeed.
Thank you so much.
It's the Metro on WDET. I'm Robyn Vincent. Coming up, we visit an overlooked city bordering Detroit and learn about what makes it so special. That's next here on the Metro. Stay with us.